Today, we're going to discuss the management of muscle-invasive bladder cancer using AUA guidelines as sort of a background for it, and then where things have moved a little further forward since the guidelines. I'll go into that. I'm Dr. Michael Cookson, professor and chair at the Department of Urology at the University of Oklahoma, and welcome to our 4th International Bladder Cancer University. So again, the basis for this 15-minute talk will be on the treatment of non-metastatic muscle-invasive bladder cancer. And these are jointly derived guidelines from the AUA, ASTRO, and the SUO. They were published in 2017 and have been amended as of 2020. So we know that muscle-invasive bladder cancer is about 25% of patients who present with bladder cancer. And it represents a significant burden and a significant risk of death from disease. And this really has changed very little over the past decades because really the presentation and the way that patients are discovered has really not changed a lot either. We believe that a multidisciplinary collaborative effort is critical to advancing this science and to reducing the burden of disease and extending survival and improving the quality of life of these patients. And these guidelines provide a risk-stratified clinical framework for the management of invasive bladder cancer. The AUA has a well-defined methodology that includes a grading system, A, B, and C, based on the strength of the evidence, well-conducted randomized clinical trials. Some of them are exceptional. Some may have some observational studies or some weaknesses that could give them perhaps a B, or if they're more observational, perhaps inconsistent results, you might get a C. And then those grades are then mirrored up with a recommendation of either a strong recommendation in which there's a substantial net benefit or harm, a moderate recommendation in which there is moderate benefit or harm, or a conditional recommendation in which there's really no apparent benefit or harm. It's kind of a tiebreaker. So we know that over the international airways, there's about 430,000 new cases of bladder cancer in the world. In the United States, 83,730 new cases in 2021, and about 17,200 bladder cancer deaths. This snapshot from the American Cancer Society kind of shows the breadth of the burden of disease in the United States when you think of the entire urinary system, which includes the urothelial tumors of the upper tract as well as the bladder. And you can also see that there's about a 3-to-1 male to female prevalence of this disease, and that becomes important too. So it's really more than just bladder cancer. We're going to focus on bladder cancer, but of course the upper tract disease is closely mirrored with this. In the guidelines, the initial evaluation includes the consideration for variant histology, and it's believed that an experienced GU pathologist should review a pathology report when you get a variant histology, particularly if there's any question about muscle invasion. And these variant histologies go by various names. They're listed here: micropapillary, nested variant, plasmacytoid, neuroendocrine, sarcomatoid, and even those with extensive squamous or glandular differentiation. Those require special attention and should be evaluated by an expert GU pathologist. In terms of the initial evaluation and counseling, patients should be considered for curative treatment options, and that should be discussed before determining their plan of therapy based on their comorbidities and the tumor characteristics as well as the staging characteristics. And the patient should undergo consideration for a multidisciplinary approach. This can include surgery, chemotherapy, and radiation. And at a minimum, this multidisciplinary approach would include potential risks and benefits of these accepted forms of therapy, taking into account the patient preference. So prior to treatment, patients should be counseled regarding complications and implications of the treatment, not just on their cancer outcome, but on their quality of life. And the quality of life impacts dramatically on patients with bladder cancer due to its impact on urinary, sexual and bowel dysfunction, as well as metabolic changes that patients can undergo during these treatments. It was felt by the guidelines panel that consideration for chemotherapy, neoadjuvant chemotherapy particularly, should be discussed with the patient, and that includes offering them the option of this with platinum-based neoadjuvant chemotherapy to those who are eligible and in consideration prior to radical cystectomy. This is based on level 1 evidence, probably around a 5% overall survival benefit if we look at the data cumulatively, but certainly should be recommended. The panel advocates platinum-based chemotherapy prior to. However, we don't really have any truly validated predictive factors that will tell us whether or not an individual patient will truly benefit from the use of neoadjuvant platinum-based chemotherapy. And we have to admit that while platinum seems to be an important ingredient, we don't know the best regimen or the duration for therapy. And so there is room for discussion with the oncology team with regard to this. And the decision regarding eligibility for platinum-based chemotherapy includes not only the patient's comorbidities and performance status, but also cardiac status, presence of neuropathy, hearing loss, and renal dysfunction can all be factors considered in the discussion about the use of platinum-based chemotherapy. Another guideline was the fact that patients should really not be prescribed carboplatinum based on the neoadjuvant regimen for those that are resectable muscle-invasive tumors. So if they're platinum ineligible, then they should proceed to definitive therapy. And the clinicians should perform radical cystectomy as soon as possible following the completion and recovery from their neoadjuvant chemotherapy. There have been many studies that have shown delays somewhere around the 3-month mark is associated with a negative outcome, higher rates of more advanced disease, and even reduced survival. So we're really on the clock with these patients, and we try to administer that consolidated therapy within 6 to 8 weeks, if not sooner, following the chemotherapy. We also, listed in the guidelines, that eligible patients who have not received platinum-based chemotherapy in the neoadjuvant setting, who then subsequently undergo cystectomy and are found to have locally advanced or node-positive disease, those patients should also be offered consideration for adjuvant platinum-based chemotherapy once recovered from their surgery. The adjuvant trials are not as well powered. The study and the data is not as robust as the neoadjuvant. However, in meta-analysis and composite data, there does appear to be benefit to platinum-based adjuvant chemotherapy in this setting. This is not in the guidelines, but this is kind of an update of many of the important trials, that some of which you will hear about in our session, that include novel agents, the use of clinical trials for immunotherapy as single agent, immunotherapy in combination with chemotherapies, and combination immunotherapies, all being studied in various settings. So here's the neoadjuvant, similarly being studied in bladder preservation regimens, which incorporate, for the most part, radiation therapy, as well as chemoimmunotherapy and combination immunotherapies, and then also immunotherapies being looked at in the adjuvant setting, and some of the trials are listed there. Clinicians should offer radical cystectomy and pelvic node dissection for surgically eligible patients with resectable non-metastatic muscle-invasive disease. And again, we've already talked about the role of neoadjuvant therapy in combination with radical cystectomy when patients are eligible. In patients undergoing cystectomy and ileal conduit, there are various forms of urinary diversion: ileal conduit, continent cutaneous, and orthotopic neobladder. All of those should be discussed. Again, like the chemotherapy discussion, there are patients who are not candidates for continent cutaneous or continent orthotopic neobladders due to perhaps renal function, dexterity, etc. But the discussion and the considerations need to be had. Also, in patients who are undergoing orthotopic urinary diversion, it's a clinical principle that a negative surgical frozen section of that apex is an important step to giving them the best chance at reduction in local recurrence. We know that in patients who are unselected, but just in general, there's anywhere from a 10 to 15% risk of urethral recurrence. It worsens with tumor multiplicity, CIS, tumor at the prostatic urethral involvement, and stromal invasion. So the importance of a negative margin is critical prior to selecting patients for perhaps a neobladder. Clinicians should also attempt to optimize patient performance status in the perioperative setting. And there's a lot of data and a lot of studies being looked at to try and improve on the patient's functional status, optimizing them ahead of surgery, nutritional counseling, trying to enhance their overall nutrition and immune status, smoking cessation. And then there's been a lot of work, and this will be discussed also later, on the sort of the early recovery pathways, minimizing some of the traditional things like the full bowel prep unless colon is going to be used or there's risk of colon involvement. So we've gotten away from that. Use of perioperative pharmacological agents to reduce the thromboembolic risks that we know are very prevalent in this population. And again, that's not a 5-7 day recommendation anymore. That's a 30-day recommendation. So patients go home on these preventive measures to reduce deep vein thrombosis in the following their cystectomy. The use of mu and opioid antagonists is also popular to try and hasten the return of bowel function, and it has been shown to do that, as well as to reduce length of stay, since diet is usually a rate limiting step in these patients. I think the caveat is they're supposed to have not been exposed to the oral opioids, which we're all trying to avoid, for a week prior to their surgery. Patients are also given detailed teaching regarding urinary diversion prior to leaving the hospital and even preoperatively. So, for example, it's definitely warranted to have an interstomal visit, even if you plan to do orthotopic diversion. In the event that that is not achievable, patients are counseled about a backup plan for urinary diversion at the time of cystectomy. And then during that recovery period, they're informed about how to help manage it. And then usually there's a bridge to home with home health, et cetera. The pelvic lymphadenectomy, it is thought to be a standard to perform bilateral pelvic lymphadenectomy at the time of radical cystectomy. And when performing these, at a minimum, there should be removal of the external, internal iliac nodes, as well as the obturator lymph nodes. That would be considered a standard lymphadenectomy. There is still active discussion and investigation about the extent of the lymph node dissection. So there's some controversy. There's definitely patients that benefit from an extended lymph node dissection, but trying to apply that to all comers has been more difficult. This was a paper published in 2019, which was a randomized clinical trial looking at the extended versus a limited node dissection. And again, from level 1 evidence, they found no difference in the recurrence-free survival with the extended as compared to the limited, but did have higher rates of Clavian grade 3 or more complications, including lymphoceles with that extended approach. This is a meta-analysis that was recently published, similarly describing perhaps the knowns and unknowns of extended pelvic lymph node. And the conclusion from the meta-analysis, which includes more than just that level 1 study, did suggest that there may be a reduced overall mortality and cancer mortality in patients with extended node, but the effect is not really proven yet. and there is evidence that it's sort of uncertain at this time. They did not find overall higher grade 3 or more complications with the extended node dissection, in contrast to that single phase 1 study that I just showed you, phase 3 study, randomized study. However, there were higher rates of other complications that were of lesser severity. So the jury's not out yet on the role of extended pelvic lymph node dissection, and there's other studies still ongoing for that. In terms of bladder preservation, patient selection is critical. And for patients with newly diagnosed disease who desire to retain their bladder, and for those with significant comorbidities in whom radical cystectomy is not a treatment option, it is felt that clinicians should offer bladder preservation when clinically appropriate. And if we were going for the best data, it is based on TURBT, systemic chemotherapy, and radiation therapy with ongoing surveillance, including cystoscopic evaluation. And this is just some composite data from the RTOG muscle-invasive bladder trials showing that overall response rates can be pretty robust, particularly in those patients who early on show a favorable response to therapy. And in well-selected patients, it can be argued that their survival is similar to those patients who undergo cystectomy. Sort of an editorial comment, you have to pick tumors that are relatively amenable to resection, so smaller tumors in general. They can't be through the back wall of the bladder, so obviously we're talking better T2A, T2B type tumors. If the cancer is causing hydronephrosis, that confounds the ability to resect it completely without obstructing them. So those patients with hydronephrosis related to their tumor are not best candidates. You have to be able to visually complete the TURBT. These patients do better if they don't have a field change. So best to select patients without associated CIS. And they have to be able to tolerate chemotherapy, which is an important component to curative bladder preservation. So this is the currently ongoing Southwest Oncology NRG 1806 study, which many of us are trying to enroll patients in, and it's looking at the value of bladder preservation in patients who are that CT2 to T4, N0, M0. There's a chemotherapy regimen, there's the radiation field, performance status and clinical stage are checked. They're randomized to concurrent chemoradiation or chemoradiation with atezo. And so it's looking at the benefit of perhaps some immune therapy layered on top of what's traditionally been chemoradiation. So patients with muscle-invasive bladder cancer who are medically fit and can consent to radical cystectomy really are better off with a radical cystectomy than a partial. So it's recommended not to undergo partial cystectomy or TUR if they're otherwise candidates. However, we know there are some patients who cannot or will not accept cystectomy. So partial cystectomy is best performed in patients who have a solitary tumor, no associated CIS, and a tumor that's amenable to a relatively good margin, perhaps as much as 2 centimeters of a negative margin, and enough capacity left in their bladder to benefit from a quality of life standpoint. So that's obviously a very small percentage of the overall bladder cancer population. It was felt that for patients with muscle-invasive disease, clinicians should not offer radiation therapy alone as curative therapy, that it would, the data is really for chemo sensitization in combination with the radiation due to high rates of pelvic failure and inability to control the tumor locally. For patients with muscle-invasive disease who have elected that multimodality bladder preservation, they should be offered a maximal TUR, chemotherapy, and combined external radiation therapy with, again, plans for reevaluation, both radiographically and repeat cystoscopic evaluation. Radiation sensitizing chemotherapy regimens include cisplatin or 5-FU and mitomycin C. That's a strong recommendation, level grade B. Addition of systemic chemotherapy has the potential to improve the local regional control, incorporating a platinum-based multi-agent regimen in the neoadjuvant setting may provide additional benefit for control of occult metastatic disease at an early stage. Following completion of bladder preservation therapy, clinicians should perform regular surveillance and CT imaging, as I mentioned previously, and this can include urinary markers such as cytology. And those patients who are biopsy-proven complete responders remain at risk for both invasive and non-invasive recurrences, including evaluation of their upper tracts, similar to their non-invasive bladder cancer patient colleagues. So in patients who fail bladder preservation, those patients then, depending on their particular situation, could be offered radical cystectomy or salvage cystectomy. For those patients who have, that's if they fail invasive. If they are non-invasive, those recurrences can often be managed with intravesical therapy, transurethral resection, and then on some, they will ultimately undergo cystectomy. For surveillance, clinicians should obtain chest imaging and cross-sectional imaging of the abdomen and pelvis with a CT or MR in 6 to 12-month intervals for the first 2 to 3 years. Usually because of the diversion and even because there is late relapses, they're followed at least annually beyond that first 2 to 3 years. But the goal here is to be more intensive in that early period, because most of the data suggests that most of the more aggressive tumors recur within that first year or two. And then radiographic evaluation, continued surveillance of their upper tracts, looking for detection in their most common sites of recurrence, as well as to monitor for upper tract deterioration and disease in the upper tracts. In terms of surveillance and follow-up, it's really important, and we are more and more aware of the need for emotional and physical and family support. The guidelines listed some, not a complete list, but certainly a good list that includes some organizations such as Beacon, as well as the Urology Health Group, bladder cancer support groups, cancer care, and cancer support community. These are important for patients at different touch points in their recovery and their follow-up, and there's a lot of resources out there for them, but they need to be directed to them. And then clinicians should, of course, continue to encourage patients with healthy lifestyle, smoking cessation, healthy diet, exercise to improve their longevity as well as their quality of life going forward. This is just an example of the algorithm that's included in the guidelines, and all of you can certainly have access to that through your apps on your phones, or you can print those out for your clinic. So this is the work of Dr. Chang and Dr. Holzberlein and the entire muscle-invasive bladder cancer panel, the AUA, and the supporting staff of the AUA. So we're really thankful for their guidance to provide these type of guidelines for us in a very clinically relevant and user-friendly way. And with that, I thank you for your attention, and we'll turn it over to the next speaker.